Dear colleagues, I'm Christoph Diener from the University of Duisburg-Essen in Germany, and I would like to make you familiar with 5 studies which were published in August 2022. Let me start with Parkinson's disease. What we learned in the last 10 years is the important role of alpha-synuclein in the pathophysiology of Parkinson's disease. It is likely that a change in the gut microbiome leads to the absorption of alpha-synuclein from the gut into the wall of the intestinal system, and from there via retrograde transport through the vagus nerve into the brain. And neuropathological studies have shown an accumulation of alpha-synuclein aggregates in important areas for Parkinson's disease. Now, the idea was to develop monoclonal antibodies against the alpha-synuclein aggregates in the brain. And there was high hope that this treatment would improve the progression of Parkinson's disease, in particular in the early phases of the disease. Now, 2 studies were published on these monoclonal antibodies in the New England Journal of Medicine. The first compound was prasinezumab, which was used in early Parkinson's disease in 2 doses given every 4 weeks compared to placebo for 1 year. And the second study was cinpanemab with a similar design, 3 different doses against placebo observed for 52 weeks. Both studies were negative for the primary endpoint and for all secondary endpoints. And this was also true in the second study for SPECT imaging. This is extremely disappointing, because we were so hopeful that finally we would have a treatment to delay the progression of Parkinson's disease. And this reminds me of all the frustrations we had with Alzheimer's disease. My next study is from stroke prevention. People who have symptomatic intracranial stenosis have a high risk of recurrent stroke after an initial stroke or TIA. And we had initially 2 studies, which are almost 10 years old, which showed that stenting is not superior to optimal medical therapy in these patients. Now, the criticism was that perhaps the selection of patients in this study was not optimal, and that the interventional neurologists were not experienced enough. Now, a 3rd study was undertaken in China, and this study included 380 patients with symptomatic high-degree intracranial stenosis and TIA or ischemic stroke, and they were randomized either to balloon dilatation and stenting plus medical therapy or medical therapy alone. The primary endpoint was stroke or death within 30 days or beyond 30 days, ipsilateral stroke and death. The study was unable to show a significant benefit of stenting compared to optimal medical therapy, and this was also true for mortality. So, ladies and gentlemen, this means now we have 3 negative studies on stenting in symptomatic intracranial stenosis. My next topic is painful diabetic polyneuropathy, a frequent problem in our everyday clinical practice. And there is a great study which was performed in the UK. These patients were randomized initially to a monotherapy with either pregabalin, amitriptyline, or duloxetine. And after 16 weeks, they also in a randomized fashion received a second therapy. So, for example, a combination of pregabalin plus amitriptyline, duloxetine plus pregabalin, or amitriptyline plus pregabalin. The overall duration of the study was 1 year, which is amazing. The results are very clear. All therapies are equally effective. And in patients where the initial monotherapy is not really effective, it makes sense to add a second drug, because then the benefit is higher. A very important study for everyday clinical practice. And my last study is a little bit out of scope of neurology, but it's very important for people who work in low and middle income countries where rheumatic heart disease is still prevalent. We all know that NOACs are superior to vitamin K antagonists for stroke prevention in patients with atrial fibrillation. But what's about people who have rheumatic heart disease and have a high degree mitral stenosis? This was investigated in a study with 4,500 patients, and they were randomized to either rivaroxaban or vitamin K antagonist. And the primary endpoint was a combination of stroke, systemic embolism, myocardial infarction, or death. To the surprise of everyone, vitamin K antagonists were superior to rivaroxaban. And this was true for the vascular endpoints and also for mortality. There was no difference in the risk of major bleeding. And this means we have now two groups of patients where NOACs should not be used. Number one, mechanical heart valves, and number two, people with atrial fibrillation due to rheumatic heart disease. Dear colleagues, 5 very important studies. Unfortunately, 3 of them frustrating because they were negative, but we shouldn't give up and continue our efforts to develop treatment, for example, for Parkinson's disease. I'm Christoph Diener from the Medical Faculty of the University of Duisburg-Essen. Thank you very much for listening and watching.